So if anybody's got a question, feel free. How did you get
And
read last week?
on the foe, you had some articles listed on there.
Yeah.
I was wondering, they're not there anymore. I was wondering if you could put either the links or the articles up again, I guess, on a separate section.
The last week, have you got it in front of you?
Not yet. One second. Yeah, it's in front of me. Yeah.
Okay, so the last week I've got is week 101. That was Sunday's makeup session.
Oh no, I
The-
have that updated area. You just
Okay,
you had some articles on there to read up, and I got all of them. So I was wondering if you could put them up again.
what were the articles?
Oh,
You don't know, do
um,
you?
yeah. Um, One of them was on the science of ultrasound. Some of them were on. You had a couple comments of, make sure your students read this. Oh,
I haven't taken anything down, at least not knowingly. Um, I'll have a look. I've got the previous faux sheet to this one. I'll have a look and see if there's a difference between them.
appreciate that. Thank you.
So it's ultrasound. Can anybody else remember ultrasound? What else? That was the last article on ultrasound. Well, actually, I should be able to find out without too much trouble right now. Hang on a second. Can't get rid of that. There's 34 results on this. Um, yeah, no, I can't. All right, I'll have a look. It'll be in the last few months anyway, will it, Roman?
Yeah, yeah. Honestly, it was just there yesterday when I looked it up, and I just didn't
Oh,
get a
really?
chance to copy it down. Yeah.
Okay, well, I definitely haven't taken it. That's strange, eh? I most certainly haven't. I haven't even touched this sheet in a few days anyway. Okay, the last one I've got in here is ultrasound, the generation of the beam and its geometry. And that was at week 95. And then I've got a note here, your ultrasound part. Oh, I think I know what happened. Needs redoing. Oh no, there it is there. So I still haven't taken anything down though. So the three I've got recently is ultrasound part one, part two, and I've got needs redoing, and then part two again, ultrasound of physics, and then ultrasound application. But they were the movies.
Yeah, no, it was below that. It was underneath the table, basically. You had a list of about maybe four
Oh,
different
you know what? I just
articles.
took it off. um, hang on a minute. Should be able to get it back with Control C. Um, all right, I'll have to look through the versions of this, which means I've got to learn how to do it again because I haven't done it in a while. I'll see what I can do, Roman. All right.
No worries. Thank you very much.
Okay. Excuse me. Okay. Anything else? Okay, then I've got something for you. I'm going to give you put a body chart up along with some information about the patient, not a lot. And then I'm going to pick one of you, and I'll pick all of you actually eventually, to make a diagnosis in about 20, 25 seconds. All right. So you get to ask as many questions or do as many tests as you want to in that time, and then I'm cutting you off.
25 seconds?
Yeah.
Okay. Like around.
The time it takes for pattern recognition is about 20 seconds. So I'm giving you extra. See, I'm being nice. But it takes about 20 seconds for pattern recognition to occur. All right. So you're good for it? You up for it?
Okay.
Okay. All right. So let me put that on full screen. I don't think I can do it. Maybe I can. Hang on. Okay, let's see. Last one on. Abhishek. All right.
Yes, everything.
That's your patient. It's a male of 20. Sorry, I've just flipped wrong. Anyway, there we go. This is a male of 22 years of age, and that's their pain right in the front of the ankle. All right. So don't worry about telling me what you're thinking. You just go ahead and make the diagnosis. So I'm your patient. You can ask any questions you want.
How
And
this pain started and when?
hang on a minute.
How this
Hang on a second. And at the end of it, at the end of all this is for everybody. I'm going to cut you off. I'm not going to ask you for what your diagnosis was. I want you to write it down. Okay? And then we'll come back to it at the end. Right? Yours. Okay, Abhishek, questions and or tests. Anything you want to ask me, I will answer you. There won't be tricks. All right? Off you go. Abhishek, I lost you. Okie dokie.
Oh,
It got stuck out there again. He has trouble with his internet. Are you back, Abhishek?
pain went off, Jim?
Okay.
Hello? Yes, questions were um, how and when this pain started.
I twisted my ankle about a month ago. It hurt on the outside, but now it's hurting in the front.
Passive motions are painful for this.
Active movements, yeah, flexion and extension. Actually, they're all a bit painful.
How the inversion and eversion?
Everything's a bit painful. Eversions, now they're all painful to some extent, but weight-bearing dorsiflexion is the worst. Stepping onto it is the worst pain.
Okay. So I was suspecting 20
No,
seconds are
Is
over.
that your only question for me?
No, there are lots more, but I thought
Okay.
only 20
Thank you
seconds
for
are
the
there.
introduction. I don't want to hear what you're thinking. All right. I
Okay.
just want you to ask me the questions, do the tests, and then write down your diagnosis, and then I'll move on. Okay.
Okay.
All
So,
right. So, yeah.
inversion and dorsiflexion together are causing pain on. It is only the anterior aspect or the lateral aspect also pains?
That's the only pain I've got. No, sorry, I've lost it again.
Hello?
That's the only pain I have, right in front of the ankle.
What relieves it? Or it's
Sorry?
only on running? What is aggravating for you? I understand dorsiflexion and plantar
Walking.
flexion.
Walking is the most aggravating thing I do.
Walking is most aggravating. Continuous pain, it is 24/7 for you. Is it a
Sorry?
continuous pain? Is it a continuous
No,
pain?
it's not continuous. You're done. All right. So write down your diagnosis and we'll move on. Okay. Hang on a second. Sorry. Sorry, Mike. I'm sticking. Shut out the daylight. Okay.
So diagnosis was muscular strain.
Just write it down.
Capital.
Don't say anything else. All right. Just write it down.
Okay,
Okay.
only right.
All
Okay.
right. Then we'll come back to it.
Okay.
Okay, Tina, there's yours. Go.
When did the pain start?
When?
Yes.
Running.
How long ago?
Oh, sorry. This is now 3 weeks.
And when do you get the pain now? Is it only when you run or like
Yeah, pretty much. If I sit for too long, I get stiff as well.
um any other like any specific movements cause problem?
No, running.
And let's see.
And you're done.
Pardon me?
What's your last question?
Oh, I was just going to say, have you ever had a problem there before?
No.
Okay.
Okay. And it's fun.
Yeah.
Actually, I'm going to change that date. No, I'm not. Sorry, there's a 46-year-old woman. That's her pain. And we'll have Roman.
How long have you had this pain for?
Well, the neck pain's been there for about 3 weeks. The headache has been there about 2 days since the last time I saw you.
Has it been gradually getting worse?
Which one?
Either.
The headache's getting worse. The neck pain is improving with the treatment.
And how did it start?
The neck pain, I don't know. No, neither am I. I don't know how they started.
Sidious. Okay. What kind of treatments have you been having already?
You've been treating it with manipulation and hot packs and exercises, and you're done. Don't tell me this ain't fun. Keep giving that one out, don't Um, there we go. Lily,
Yes. Oh,
off you go.
anterior oval pain. Okay. Uh, what started the pain, if you know?
Don't know.
Okay. Um, what does the pain feel like? What quality of pain is it?
It's really a ache, but when I use it heavy, then it's painful. And you're done as well. Write it down.
That's
All right,
it.
write your diagnosis
Okay.
down.
Just three
You've got 20
questions.
seconds. It
Okay.
ain't a long time.
Okay. Okay.
And that one. Done that one. I keep giving you. I'm going to change this pain. All right. This is a 40-year-old, and it ain't a fracture. Okay. That's a bit technical. No, I won't do that. It's nasty. We'll do that instead. All right. So this will be Scott.
Yes. Does it hurt when you put your arm above your head?
Hurts.
Hurts across your body?
Not particularly.
How about if you put your arm behind you and bend your elbow?
Well, that hurts.
That hurts?
Yeah.
Okay. Got it.
You got it?
Got it.
Okay. Write it down. I don't. Right, I'm going to change this one as well. Who else we got to go? Roman. And we will do this to you.
I already got the neck one.
Hmm?
You already gave me the neck one.
Oh,
Neck and
sorry.
headache.
Todd, I think you're there, aren't you? Yeah. There you go, Todd. Right there.
How long has the pain been going on?
3 weeks.
How'd you do it? Do you know how you did it?
I don't know.
What's in? Is it sharp, dull, achy, throbbing? How would you describe it?
No, it's sort of pins and needles.
Do you notice across your whole hand, or just pins and needles at the
Now
neck?
that spot right in front of the wrist.
And then any motion restrictions or how it hurts to go up or down?
No, I can move the wrist everywhere. And you're done. All right, is everybody got? Did we do
One more question I thought I was
everybody?
going to get.
Who? Is that everybody? I think it is, isn't it? Okay, Todd, what was yours?
So with that, I was trying to distinguish whether it's going to be like a biomechanical dysfunction or more like a carpal tunnel type syndrome, but I didn't
Well,
get
you got
the
a
actual.
choice. Which one you going for?
I'll take the carpal tunnel, I guess, to start out.
Yeah, I mean, it's not typical carpal tunnel, is it?
No, it
I
wouldn't
mean,
be.
that usually shoots into the hands, but it's neurological. And that might be the best you can say. There might be a ganglion in there or something, but it's neurological. Fair enough.
Yes.
That was the only question you really needed to ask. Doesn't matter how long it's been there, does it? Under those circumstances. But I bet you heuristic with either a biomechanical dysfunction, which is unusual to be felt in the front of the wrist, isn't it? Or probably your second thought was it was neurological, or the other way around, yeah?
Yes.
Yeah. So you can get rid of one of these really easy. Is this neuropathic pain? And you couldn't get rid of it. A neuropathic pain is pathognomic of neurological problems. Yeah.
Yes.
So that's your way into this. Get rid of the stuff that takes longer to deal with, and off you go. Okay, who had that one?
Muscular strain, I was thinking. because it was
Oh,
more inactive. मतलब in active movements, dorsiflexion or plantar flexion, more in dorsiflexion. So can be a tibialis anterior strain. So
so what
more
was your
along
diagnosis?
the strain, tibialis anterior muscular strain.
This one you'd have done better going straight into a test.
Come
In the
again.
front of the ankle, so you can either palpate the tendon or you can
Palpate the
try and
tendon.
slide the
That's the
talus.
hmm.
Yeah, I mean, asking about movements doesn't really help you. If it gets pain on movement, then it can be muscle, it can be joint. It doesn't really help you differentiate this
Right.
out. Yeah, so
Okay.
you'd have probably done better just going in and palpate the tendons if you were seeking tendons.
Okay.
All right. This one, who was it?
That's me.
Okay, Roman.
Um, uh, First thing that I had in my head after you said 3 weeks was a joint dysfunction, and that I've been treating it. And so with the headache only being there 2 days, in my head now I'm thinking, did I cause any kind of a bleed with treatment?
It's very, very unlikely, given she's 46 years of age and you're not smacking her head against a wall.
Okay.
All
In
right.
that case, then I will still go with a joint dysfunction, upper cervical, um, cranial, vertebral joints.
Okay. For me, the fact that the neck was improving and then she's got referred pain means it probably isn't referred pain.
Hmm.
What I would have done with her is done the tap test, see if she had sinus. It's the easiest one to get rid of.
Sorry,
Go
temp
straight
test?
into a test. And the other thing you could do is try to associate the neck pain with the headache in your question.
Yeah,
Again, it doesn't really matter how long she's had it. Doesn't really. All you need to establish is that the sequence of it. Did the headache come on before the neck pain? Did the neck pain come on before the headache, or what?
yeah.
Yeah, as far as the duration is concerned, it really doesn't help any.
Huh.
Yeah.
What's the tap test? Sorry.
Sorry. Okay. Well, if it's on the front, these are gravity-dependent headaches. The sinuses. So you put the head forward and then
Yeah.
you tap them over the sinus, and that
Huh?
can be really painful.
Hmm.
Now, if it isn't, it doesn't prove it's not a sinus, but if it is, it really does demonstrate the sinus. Yeah,
So, okay. I've never heard of that one.
there you go.
Okay.
I try to teach something every now and then.
Hey, Jimmy, would you include in this case, in the next case, anything to do with the TMJ for referral?
No, you've got 20 seconds.
Okay. Catch.
Again, it's unlikely to be referred from TMJ up that high. And isolated referred pain is not common. It does happen, but it's not common. Yeah, if you get elbow pain, and if you've got isolated elbow pain, it's almost certainly going to be local to the elbow. You're going to have local pain, if not topographically connected pain, which is the more usual one. Pain in the source and pain like distally. So don't start thinking, the first thing that shouldn't go into your head is, this is rare. Okay? If you think back to all the patients you've seen, how many of them have referred pain but no local pain?
Yeah.
The trouble is, you remember the cases that happen and you don't remember the cases that don't happen. So the cases that do happen, you may see 5 over your career. That's a lot. It's a lot, isn't it? It's a lot more than you remember the other way around because you don't remember the other ones. They're normal. Yeah. But it's very unusual that see a lot isolated referred pain.
Interesting.
That one. Now, whose is this?
Tina's.
Tina.
Me?
What we've been talking about, what should your test have been?
What should my test have been?
Yeah.
Like,
Instead of the questions you gave me, what should the test have been?
Mhm. Like,
You had a
like
heuristic in mind. What was it?
I just thought it was biomechanical dysfunction.
Okay, then you do a PA. Or, given where the pain is, you do Fortin's test.
Mm.
Yeah.
Yep. Gotcha.
This is what experts do with pattern recognition. All right. It's not that they don't ask questions and do tests, they do, but they pick the questions and the tests.
Mm.
And they don't even know they're doing it. What I'm trying to get you out of is the idea. I think what I'd like you to do is try and think that you're in a clinic when we're doing this type of thing, not in a class. All right? Because half the time you give me the answers you think I want, and you have no idea what answers I want. And I'm a rotten sort, so it's unlikely to be the one you think I want. SIJ, Fortins would have been positive.
Mm. Gotcha.
Mm-hmm.
Lily, was this yours?
Oh, I got that one, Jim. I thought it was possibly a biceps tendon strain.
Okay, what was the questions you asked me?
Well, I didn't get to ask many, but you said that it hurts when you lift something heavy, so
Yeah.
it seemed like,
Okay, what would you have done better there? In the time you had, what was the best test you could have done?
oh, I would probably if it's tender at the spot.
Yeah, palpate it. That's your quickest test. It's the most specific test you have in that time. Why not do that?
Hmm.
Because all you're doing is guessing. I've got pain in the front of the elbow. The biceps. Actually, is it biceps brachialis? Which one? You might have been able to tell that from the from palpation. How deep did you have to go for this to be painful? Then you could have said biceps.
Hmm.
Yeah. And who am I missing? Anybody? Scott,
Yep.
what was yours? Because I've taken it down.
Shoulder, bicep tendinosynovitis.
Sorry, say again.
Bicep tendinosynovitis based on range of motion, painful of the head, and mildly painful with the arm height.
Okay, what should you have done?
Palpate the tendon.
Yeah,
Yep.
yeah. All right. We're all programmed to do a history and then do an objective exam. But with that shoulder one, you got pain in this area. Yeah. I don't know if you can see me or not. Let me take this down. Where am I? I've disappeared from view. I don't exist. I'm not there. That's
We
weird.
can see you, Jim.
You're on.
Okay. Oh, here I'm probably at this end. There we go. I'm first in line. So you've got pain in that area.
Right.
That means you've got, I'm writing this up at the moment. I think you've got, in that area, you've got enough tissues. If you do 2 questions and 2 tests on every one of those tissues, it's 28 questions or tests to include a tissue in there at a minimum, an absolute minimum. You're going to spend 28 questions or tests identifying it. You don't. You get rid of stuff. You need 1 question or test to get rid of it. That's it. So the shoulder, the reason the shoulder is such a mess is there's so many candidates there. It's not that it's particularly difficult, it's just there's so many different problems that can occur there because of all the different tissues around it. So get rid of them. Falsification is your friend.
Right.
Yeah. Is that useful?
Yes. That was
Want
good.
more of them? Not right now, I've got to figure out things. It's a bit like hard work. So, all right, we'll do more of these because I think they're useful to you. Just remember this, son. You need to treat this like your clinic. Don't try to answer the way I want them answered. And actually, you're not even doing that because you know damn well I don't want a heuristic. And you know that. But you keep giving them to me. Yeah. You've only got 20 seconds to do this, and you've got to prioritize the question. And that's where it takes an expert to recognize a pattern. What they actually do is it's not just memory. It isn't that at all. This is parallel processing. They take the heuristic, all right, they're running it through about 2 or 3 differential diagnoses. This is all subconscious. They're running it through 2 or 3 differential diagnoses. At the same time, they're asking you questions and including that information as well. So this is all specific stuff they're doing. And at the same time, they're comparing everything to previous patterns that they have embedded. Okay. And I don't know if you're doing it or not. You may well be. It's really difficult to test for, and that's what I'm trying to do now. And I know what's happening is you're basically not seeing this as a clinical problem. But let me G you up a bit. If anybody wants to do this exam, this type of question will be included in it. All right. When I was teaching at university, I remember this. Like somebody said to me, is this going to be on the exam? And like an idiot, I said, probably not. And I said, everybody relax. Oh, you bastards. The next time I was asked that, I said yes. Every single time they asked that question, it was yes, whether I intended to or not after that. And they stopped paying attention the minute I said it's not on the exam. So I'm trying this on you. It will be on the exam. All right. Have you got questions for me? You want to talk about that exercise some more?
Hey, Jimmy, on the impingement for the hip,
Yeah.
it talked, in the article, you talked about, the cam and the pincher, if they do have pain, say they're a runner, and they do have pain, the question becomes, like you said, either stress fracture or impingement. I mean, it's one of those, but and you said the gold standard, of course, is MRI, but if you get an X-ray that's negative, do we treat it? I mean, do we treat it, manipulatively? Would we?
Now, hang on. What's the diagnosis you've made?
Well, if they have
The only thing that matters for your treatment is the diagnosis that you make, not the MRI, not the X-ray, not the doctor's opinion.
But okay, so I guess my question: if they had achy, deep pain in their hip after running, and then it did get better without being stressed, I guess I'm asking: could we assume it could be a stress fracture?
Well, you need to look at the illness script of the stress fracture, don't you?
Right. No, exactly. Right. No, I understand. Okay.
So that's a question. Have you seen hip stress fractures before?
Yes.
Okay. Do they behave like a labral tear?
No.
That's your impingement, basically.
Right. Right.
As far as the femoral acetabular impingement is concerned, understand that they're not that common. All right. Doesn't mean to say they don't exist, but they're not very common, which means that's not the first thing you think about. Also, do they, well, they don't. These are pinch syndromes, as you say, they're true pinching syndromes. So you're not going to get the same build-up, the gradual build-up that a stress fracture will give you. So this is typical stress fracture that gradually increase in pain with exertion, not exertion, but overuse. Well, I think it's overuse, which means walking more than 3 minutes. But there are clearly doing more than the average. All right. So this thing I would class is overuse, but they're using it a lot. So that's your first clue. They're using it a lot. And then you have a gradual increase in pain and a decrease in function to the point where they have to stop doing what they're doing. That's your stress fracture, isn't it?
Okay.
Or you'll get that happening, and then you'll get an overt fracture in it. So it'll go from that gradually increasing pain through overuse, and then bang, then it catches you. So it's going to be one of those two presentations. Doesn't look anything like an impingement or a labral tear come with it.
Jim, last time you also said a stress fracture would limit motion.
I said a fracture will limit motion.
A stress fracture.
No, I didn't say that. We were talking about painless fracturing, weren't we? Traumatic painless fracturing.
Yes.
This was only a week or two back, wasn't it?
Yes.
Yeah, we were talking about painless fracturing from pathology.
Yeah.
Yeah, that's not a stress
Oh, yeah,
fracture.
especially in the neck. That was what it
Yeah.
was.
Yeah, that's
Yeah.
a pathological fracture. But that will
And then
that will limit range of motion. The stress fracture may not.
Oh, I got you. Yeah, I got you
Yeah.
now.
Is that right, Scott?
No, that's no, that's good. It helps. Now, question I do have though, if somebody did have a stress fracture, say their medial femoral condyle, hypothetical, and you knew it, and based on, I mean, they came in, you saw them, and they did have imaging, and it did show that. Can we use ultrasound, 20 minutes kind of thing to help heal that?
No, probably not.
No.
This is 20 minutes of ultrasound every day,
Every day.
and it's fixed, so it just stays where it is. You can't move it. And if you do move it, you have to make that time up. So if you're twitching around or the patient's twitching around, then basically you have to add that time in. So you could be there 30, 40 minutes. So logistically, you're getting paid, what is it, $15 a treatment?
Right.
So financially, it makes no sense. Secondly, the pulse isn't really set for it. It tends to be of a too high intensity. So the pulses they'll use is anywhere between, I think it's 0.1 and actually that's not true. I think they use 0.1, but it's somewhat effective up to 0.5. I'll say that again, 0.5. But it's the lower frequencies that do better. Lower intensity that do better, rather. All right. So you're not equipped to do it. Plus the fact you've got, now the hip's not bad. If you're going to go through the front of the hip, it's not terrible. Sorry, the back of the hip, because that intensity will attenuate on your way into it. So you may end up at 0.1 eventually. You go through the front though, and that's fairly superficial. So
Okay.
you're going to put this on the lowest settings and sit with them for at least 20 minutes, counting the seconds and making up those seconds if you move. You're not equipped to do it. Why would you want to do it?
Yeah.
What they do with what the units that are designed for it have a fixed frequency, fixed intensity. I think they have a fixed frequency, and they clip onto the patient. And given that the units cost twice knows how much, it's very unlikely that they wouldn't be using our ultrasound to do the job if they could. I don't know why you'd want to be honest with you. And how long will it take? This is not a quick
Right.
treatment. And can the patient keep affording it? We've both got our countries in both countries because they're both rationed. The treatments are rationed. Yours is rationed by how much money you've got in your bank, and ours is rationed by 12 or whatever it is now. So now you're paying 100 in Canada anyway. You'll be paying $100 a day, I'm sure, for us to do it. Over I really don't know how many months, but it's not going to be quick. And to be honest with you, I should find this out. I don't know if ultrasound, and somebody can enlighten me if they would, is any better than electrical stim for stress fracture. Anybody know?
I don't know.
No. I can find out, I guess. Hang on a bit.
Yeah.
I could have if I lost it.
Jim, are you looking up like Gemini wise?
Yeah.
Yeah, so I looked it up. It says low intensity pulse ultrasound generally holds stronger, high quality clinical evidence for managing non-union delayed union stress fractures compared to electrical stim.
Okay, great.
It goes on to say a lot more, but that's kind of the summary.
Excellent. Thank you, mate. What are the times for this anyway? Healing time. Ultrasound. Expected resolution window 4 to 8 weeks, depending on site and grade. And it brings it it brings it down from 8 to 12 weeks. So it makes about a month's worth of difference.
Yeah, that's interesting.
Okay, thank you for the information, guys. You look it up.
I mean, 20 minutes daily, it almost doesn't sound realistic for most people, though.
No, it doesn't. I don't. It's possible. I wonder if they give him a loaner. Let me see.
You can do what?
Give a loaner out.
Oh, you could.
I can do that easily. I'm not sure they let me. No, I don't let them out.
But Jim, doesn't a stress fracture, wouldn't that heal like normally with
Rest.
rest and
Yeah, it
8 to
shaves
10
off
weeks
4 weeks.
anyways?
Yeah, it shaves off 4 weeks from the time. But
So if it's normally 8 to 10 weeks for a fracture to heal, then if you use the ultrasound, wouldn't it be like faster than that?
yeah, the faster the ultrasound does it in 8 to 12 weeks. The not using ultrasound does it in 12. Was it 12 to 16 weeks? It takes about a month longer without ultrasound. Okay. I think they tend to use this with unhealed fatigue, stress fractures.
I see. And like non-union ones. Yeah, I remember you
Yeah.
asking well, Mercy had asked a question about how these non-union fractures were managed now without casting.
Oh, the boot. Yeah. Yeah, that makes no sense to me what they're doing there at all. And apparently they
Yeah,
do
I
it 3
remember
to
I
5
had
times a
someone with
week.
a
Oh,
fibular
sorry.
non-union fracture,
Sorry.
and they were not casted either and were not restricted. I
Yeah,
thought
it
that was
makes no
kind of,
sense to me. The
yeah, it
reason
didn't
that
make sense to me
the
either.
reason they've stopped putting them in boots, apparently, is to stop adhesions forming. Well, there ain't any adhesions. There's no bleeding going on, so there's no adhesions occurring. So I don't know where they get that from. So you don't have to worry about stiffness because stiffness comes from adhesions. The other way stiffness forms is loss of sarcomeres in muscles that are immobilized. Well, that's easy. You take the boot off every hour, move your foot around without weight bearing through it, without shearing it, and put the boot back on. And you also keep the compression because the boot doesn't stop compression going, which is what you want for healing. I don't know why they stopped using the boot. Makes no sense.
And also, it seems like it would uh, be like not in alignment then. You'd have more chances
Well,
of
there's not
getting
an
your
alignment
spine,
problem.
I mean, your fracture misaligned.
No, it's not displaced.
Right, but I mean, if you don't boot it or cast it, you probably might get it misaligned.
No. This isn't casting like that. They're not casting it for that. They're casting it for to stop stiffness. This the only way this would displace if you have an overt fracture through it. And as soon as you stop stressing the thing, that's not likely to happen.
Right, I know, but if you're allowed to walk on it without uh
Well, you're not
stabilizing
allowed
it,
to walk on
then
it, are you?
no, that's what I'm saying. They are. They
No,
are
they
allowed
shouldn't
to walk.
be. They should be on crutches, non-weight bearing.
Right, exactly. That's what I'm saying. If they're not um casted or immobilized and not and
I'm not
allowed
sure
to
a cast
walk
is a
on
good
it.
idea. A casting's not a good idea, is it? You want compression. You need compression through that fracture. That stimulates healing.
Hmm.
So a cast isn't going to work for you. And I think whether or not you would put it in a cast would depend on the grade of the fracture as well.
Well, maybe even, but a boot, doesn't it seem like you would want to that you could put weight through it, but wouldn't you want to
Yeah, that's
restrict
what I'm
the
saying to you. It
movement a
makes no
little?
sense to stop using boots. That's what I've been saying.
Yeah,
It makes no sense
yeah.
to stop it, to me anyway. But what do I
Well,
know?
that's what I would think.
Yeah. Apparently, just reading a bit more with the ultrasound stuff, they're treated 3 to 5 times a week. I'm not sure I'd bother.
Because it won't get to the bone from what I read.
Sorry, say again?
It's not going to get deep enough to go to the bone.
Oh, yeah, it goes to the bone. I mean, they're designed to do exactly that. So, and I really don't know the ins and outs of it, but you can get, if you're on a superficial bone, that will go straight through the subcutaneous fat without any attenuation at all. It'll just go straight through that. There's no absorption, no attenuation. You'll go through the skin and fat, go through the periosteum, straight onto the bone. So if this is superficial, you're going to get whatever you've got on the dial in the bone. The deeper it is, the more attenuation occurs. Now, I don't know what they do with deep bone. It's possible they do what they do with intracranial surgery. They use very, very low intensity pulses, lasers, but lots of them, and then focus it. And I think the wattage in intracranial surgery with ultrasound is, or the frequency rather, runs to about 10,000 cycles per second, as opposed to the 3 million that we're using. So it's very, very low frequency, but there's lots of them. Anyway,
Because
it's got to get, like, if it doesn't get to the bone, it's not going to work, is it? So it's got to get to the bone.
well, and you have to use like 0.03 watts per centimeter squared to even get down to the bone for healing osteoblast cells.
Yeah, but the intensity doesn't determine how far down you go. It's the frequency that determines the
depth.
yeah.
Okay.
the attenuation that occurs follows the inverse square law. So you've got that first part of the attenuation, which is in the near field, which is, oh, that's the, hang on. No, that's the half depth value. In the near field, it's a half depth value. So at 1 centimeter is, was it 1 megabyte, 1 megahertz, or it might be 3. But anyway, one of them, you'll lose half the value in the first centimeter. I think that's the high frequency.
Huh.
On the, yeah, I think so. Anyway, I think that's the half. Anyway, you lose half the value of the intensity in that first centimeter. Once you're out of the near field, then attenuation takes over, and that's the inverse square law. But if the sound wave doesn't get down to the tissue, there's no point in giving it. So, and if you think about the sites where stress fractures occur, they all tend to be fairly superficial, don't they? You've got the tibia, top and bottom,
Patella, right?
yeah, and you've got the fibula. What else? With the metatarsals,
Patella.
yeah. So all of these are fairly superficial, so you should be able to get it there okay.
Unless it's the hip.
Yeah. You can get to it from the front. I'll see what I'll find out about that. And on that now.
Jim, do you think that ultrasound helps like an arthritic hip?
No, I shouldn't think so. If for no other reason that you've got to look at the area that you're insulating. So if every time you move the sound head, you dilute the dosage. So you're going to have to smear this over the whole of the hip. Now, that means it's got to go on continuous. Yeah? Otherwise, you're going to be there for a month and a half before you can get halfway around it. So it's got to be on continuous. From the front, if you've got somebody who's not got a lot of muscle, you could use high frequency. Just about. But that will only get the front of the hip. Now, when you want to get to the back of the hip, you've got to go through the glutes, and you've got a bigger problem on your hand there. So just from the delivery side of this, I wouldn't think that ultrasound or a big joint anywhere is going to be very beneficial. You've got to have focal lesions here, I think, for it to be of any use.
Also, probably, was there a contraindication to using ultrasound over an artery,
No,
like femoral artery?
no, not as far as I know.
Okay.
Um,
Well, what about for a hip bursitis? I think
well,
that
if you can get to it, you
I've
can do
used
it.
it commonly for that.
Yeah, I mean, if you can get to it, you can do it.
Okay.
This is what I mean. You've got to know how deep it is, what intensity you're going to use. Are you going to use continuous or not? And you've got to know about the blood supply. How good or bad is the blood supply to that tissue? Within reason. So if you've got somebody with arterial disease, you won't want to use continuous shortwave, continuous ultrasound. That means that you're going to basically, even on the best day, double your treatment time if you're using 50% pulse. Now, how big is the area? How often are you going to cover each spot in a given time?
Well, for hip bursitis, maybe it'd be about to 2-inch diameter, 2 or 3 inch diameter. So just a little bit bigger than the sound head, but the sound head isn't delivering it across the whole face of it. So
Well, again, though, the fatigue fracture isn't a single line, is it? It's an area of bone that's fatigued. Now, what am I talking about? Bursa. The bursa is not a single line. Rather, back to the fracture.
no,
It's
it
not a
would
single line.
have
So
to.
you've got to cover that. And if you can do it with the sound edge, then you can keep it still. If you keep it still, though, it's unlikely that you can use a high enough intensity and keep it on constant, on continuous. You can try and just keep dropping the frequency, the intensity down, but every time you drop the intensity down, the time has to go back up again. So anytime you move this, anytime you put it on pulse, anytime what's the other one? Another one. Anytime you change the way that bean's being delivered, you have to change the delivery time. There's no way around that. Yeah, it's saying here the target's too deep for ultrasound. The attenuation, the weakening of the beam brings it down to an ineffective dose. So they tend to use electrical stim. Yeah. Okay.
Jim, can I ask
There
a
are
question
places
about
you
the hip?
can't use it. It's as simple as that. You really can't. But it's a little bit complicated. Ultrasound's a hell of a lot more complicated than they teach in school. Hey, got anything else for me?
That was good.
Jim, can I ask another question about the hip since we were on it?
Sure. What?
Uh, so, um, if the hip is clunky, like it's a consistently clunky and painful to put weight on it, and you suspect it's arthritis now or
What job are you
degenerative.
talking about?
The hip.
Okay.
So then, is there anything we can do about it?
Well, how do you treat arthritis or arthrosis? I mean, the principle's always the same, isn't it? It doesn't matter what joint you're talking about. The way you treat arthrosis is the way you're going to treat it in any joint you find.
Improve the range of motion so that I can get some joint nutrition?
What would you normally do with the knee?
I think that's what I would do.
Well, there you go.
Improve the joint motion so it would get the
Yeah,
joint
but you're asking
nutrition.
how to do it. So you do it exactly the
Yeah,
same
no,
way
but
as
I'm
you do
asking
for the
if
knee.
we could do anything if it's really
Probably not very
clunky and
much. No, probably not very much. If it's
so
far gone,
this
that's
is
why
one
they
of
do
those.
surgery. That's exactly why. If you're starting to get crepitus from bone to bone contact and a lot of heavy
Right.
clunking, then that joint is unstable, seriously degenerated, and really it's surgery.
That's what I was thinking. But
Is that
you
you?
know, no, it's not me. No, it's my friend. But I, yeah, it seems like it's one of those cases where you can't fix everything.
No, I mean you can't fix most things, Lily. And I mean that even with orthopedics, you don't fix them. You sort of, what's a mechanic do? Just to keep it
Well, if
running
it's
for a bit
mechanical,
longer.
it seems like we can fix it.
No, you can't. It breaks again, doesn't it?
Well, you got to
The most you
keep
can do is
those
jack the
tailors
car
in.
up a bit, give it a kick, put it down, let it run for as long as it's going to run.
And then you get to fix it again.
Yeah. See, it's money, isn't it? So you make your money.
Well, everybody's like that. I mean, we're
Yeah.
gonna like wear out and then you have to fix it. I mean,
Yeah. Uh, anybody in Alberta, really, or anywhere, really? Bob Sydenham retired. Did you know that, Tina? No, no, he retired at May, I think it was. And he's moving to Lethbridge.
Oh, you'll have a pal.
Yeah, that's what we said. The phone calls will go quicker. He was a very, very good therapist. Yeah. Okie dokie. All right, got nothing for me? And I will bid you goodbye.
Thanks, Jimmy. Have a good week.
All right, you too. Take care.
Thanks, Jim.
Too.
Bye.
hey, thanks, Jim.
See ya.